Okay, so good morning, everyone, and welcome to what is actually the 10th year that the FND Awareness Day UK has been held. It
It's been
started in
held.
2017, and since then we've held many events, none as big as this one. This is the largest event we've ever had in terms of participants, which is great, and perhaps highlights the extent to which FND is now being diagnosed, and the amount of new people and new people being diagnosed with it all the time. So, welcome to this event. We have two events online today. This one, which we'll do a proper introduction to Dr. Niels Detert in a moment, and then the arts session this afternoon, which will be a bit more of a relaxed session that won't be recorded. Just a bit of like a more of a therapeutic sort of session, which I think we'll all need after this one, with the amount of people here. But I'm going to stop sharing that. And I'm now going to hand over to Dr. Niels Dieter. Niels, would you like me to do your formal introduction and start, or would you like to do that yourself?
Um, you could say a little bit, Steve, and I'll say a little bit more.
Okay, fair enough. Lovely. I've got my notes here just so I get the title right. So we're delighted to welcome along Dr. Niels Detert today. Niels is a consultant clinical neuropsychologist and the lead for adult neuropsychology at the John Radcliffe Hospital in Oxford. Um, we, as charities, come across Niles quite regularly as part of the UK FND network, of which Niles is the chair of that group. That network is a collaboration between the FND voluntary sector, the charities, and clinicians like Niles, people like John Stone, who I'm sure many of you know him, other key clinicians in the FND field from other sectors, from occupational therapy, from physiotherapy, all the disciplinaries as much as possible. GPs are now joining it as well. So the depth of that network is becoming broader and broader and broader all the time, which is great in terms of expanding um, and banging the drum for FND services across the UK. So without further ado, you'll be pleased to hear I'm going to shut up and I'm going to hand over to Niles, who will be sharing his screen and presentation. And once again, if I can just remind everyone to please star mute during the presentation so we don't have any interruptions. Thank you very much. Thank you, Niles.
Oh, thank you, Steve. That was a really nice introduction. So I'm glad you did that. I don't need to add any more. So thank you so much for inviting me as well, Steve and Kim and Mandy from FND Dimensions, FND Action, FND Friends. I'm really delighted to be here talking to everybody and looking forward to it. And I hope it will be quite relaxing for you, and you won't need the art session just to relax from this one. I might need the art session to relax from this one, but I hope for you it'll be interesting and enjoyable. So I'm just going to share my screen and make a start. Let's see here. Okay, so I'm just going to minimize all the faces so that I can see my own screen. Great. Summaries. It's getting in the way. Good. Got it. So FND, A New Era. And I really like this title. It's given to me by Steve and Mandy, because I think that there is something of a new era. It's not like sort of something which is happening very suddenly or immediately, but it's happening gradually, and there are some positive signs. And I'm going to talk about those um, amongst other things in this talk. What I will talk about is the overall picture, where we're at, where we're headed, what the positive signs are. And a lot of the talk will be about what FND is, because I think that understanding FND is one of the main issues that we are facing. But let me get into it, and I'll cover those points as we as we go. Press my button. That's that. Okay, good. So FND is a serious illness, like other serious illnesses. And I don't have to read down this list of the sorts of problems that people with FND have, because you're all aware of this. There can be significant disability. There are a variety of neurological problems. It can have a significant impact on people's lives, on ability to be independent and work. It can have it can be a big stress. It can cause depression, poverty for some people, these sorts of things, and it's a burden on society. It's the second commonest reason to see a neurologist. You'll all be aware of those things. So, so then, my question is: so why are we here today in FND Awareness Day? And the reason is that I think we're suffering from a lack of understanding. That has led to a lack of services. And so FND awareness is really crucial. And as recently, I think last night, I sort of remembered a line from the film I Swear. And I wonder if any of you have seen that film, which just won a BAFTA. And tells the story of the life of John Davidson, who's got Tourette's syndrome. And there's a line in that film where a friend of his says to him, you know, John, I don't think, he says it in a Scottish accent, but I'm not going to try and do that. You know, John, I think the problem is not so much with Tourette's. The problem is people not understanding Tourette's. And I think that that's really true with Tourette's. And I think it's also true with FND. And I'm highlighting that right now. So here is a slide about some of the problems which hopefully are beginning to improve, but they haven't gone away yet. There have been systemic issues in the services that people with FND have got from the health service. There has been no service in the past, which is beginning to change. It's changed a fair bit. And the fact that there's no service, you look at that kind of little vicious circle on the left of the slide there, no service, led to doctors feeling powerless and, saying it's not my problem, not a physical health problem, not a real problem. There's a lack of understanding there. Maybe people would be sent to mental health services who didn't feel it was their problem either. And so you sort of go around in a circle like that. One of the key missing ingredients in this circle is the lack of a service for something for people to be actually helped. And one of the effects of this kind of cycle has been historically, and sadly it's not gone away yet, that people have felt dismissed or not respected or not believed. And a high percentage of people in an informal service said that that was their experience. And I think that that fits with what I hear from patients as well. So that even worse than not providing a service, what we had in the old days, I think this has improved a lot now, what we had in the old days was a service set up which actually caused harm by dismissing people and not giving them a service. Happily, we're moving away from that. There's room for improvement, but things are much better. So I hope from now on, the slide's going to get a little bit more hopeful. So moving on, let's have a quick look at my checklist of what's needed. And we'll come back to it at the end and put in some ticks and crosses here and maybe the odd question mark. What do we need to provide adequately for people with FND? We need a scientific and a clinical understanding of what it is to enable diagnosis and management and treatment. We need patients to understand what it is, to give people confidence in the treatment and to feel empowered to do what they can. We need healthcare workers, other than the specialists, to have an understanding so that we can enable actually caring pathways and so that people don't encounter stigma and dismissing statements along their way. We need society to understand what FND is so that that can reduce stigma and unlock resources, because it's only when society understands it and values the services that people with FND need that will make money more likely to become available. And we need treatments. Obviously, we need treatments in order to treat or rehabilitate people and to reduce disability, to actually improve people's health situation. We need national policy to enable service development across the country. And we need actual FND treatment services. We don't just need a theoretical understanding of what will help. We need services which are there, which people can access, which can help them, and that will break the negative cycle I was talking about, and which is already breaking. Spoiler alert, some of these will have ticks already, and some of them not so much, and we'll have a look at that. So moving on. Let's begin. Oh, I'm just going to go back again to that last slide. I'm just going to notice, just going to notice with you that out of these things that we need, more than half of them are about awareness and understanding. So that's because I think it's so important. So one of the key questions is, what is FND? If we need to improve awareness understanding, we need to improve people actually understanding what it is. But it's not easy to understand, right? FND has physical symptoms, but there's no physical pathology. And that is already a little bit confusing. It's one of the things that has led to problems in the past. So, but even though it's like that, it's not a mild condition. It's often severe and disabling, although it varies a lot. You do have people with milder symptoms, but it's often not mild at all. The elephant in the room, I like this picture of the elephant, and it's obviously a bit of a kind of play on words to call it the elephant in the room. This elephant illustrates the ancient Eastern story of the elephant and the blind men. I'm sure you've come across this story. I think I probably came across it on children's TV when I was little. You come across it periodically. And the idea is that the blind men can't see the elephant. All they can do is touch it. And because it's so big, they just touch one bit of it. And the one says, oh, it's like a tree trunk. And the other one says, oh, it's like a huge leaf. And another one says, oh, it's like a broom. And somebody else says it's like a snake. And the other one says it's like whatever the tusk would be, like a sharp pointy thing. And so nobody gets the whole thing. So the reason I put this picture here is that this is a little bit like the situation in FND, where FND has multiple aspects. And in particular, it has both a body, a physical aspect, and a mind, a psychological aspect. And that's something which most people find difficult to understand, because we're stuck in what I would call mind-body dualism, where we think of the mind and the body as separate. But of course, and we'll be talking about the detail of this, but of course, the mind and the body are not separate. They are both the same thing. The brain is one thing, and some things that the brain does we call mind, and other things that the brain does we call body. And yet that is difficult to get across to people. So it's puzzling, and there have been misunderstandings, and there are myths amongst lay people, amongst patients, and amongst clinicians. And let's have a look at those myths, which are basically some wrong ideas. And you'll recognize these. Many of them have not completely gone away either, which is why I'm mentioning them. So these myths about FND, we're not just talking about a lack of understanding here, we're talking about wrong understanding. So let's run through some of these things. It's all in the patient's head. Normal scans mean nothing is wrong. FND is malingering. Patients exaggerate. Even though some of this seems quite extreme to you, you come across this even now sometimes, these kinds of things. FND is due to secondary gain illness behavior. FND is psychological. FND is just anxiety or depression. FND is always caused by trauma. Diagnosis is only by exclusion. If there's no structural damage, then recovery should be quick. On the other hand, once you're diagnosed, you never recover, or FND can't be treated, or only neurologists or only psychiatrists can manage FND, or FND is rare, or FND is new. None of these statements is true, but you will have come across probably all of these ideas from somewhere or other. It was worse in the past, but it's still there. So let's have a look through these things. The myths. So some of these are about it not being real, or it's a diagnosis of exclusion, or it's exaggerated, and so on. So let's look. So you come across the idea that it's in the patient's head that normal scans mean nothing is wrong, and the FND is malingering, that diagnosis by exclusion. This implies that the patient is imagining or putting the symptoms on. In fact, symptoms are real and involuntary. This is absolutely clear to us these days. And the diagnosis is by positive signs. In fact, there are characteristic physical features of people with FND which make that the diagnosis. We're not just sort of hunting for an illness, not finding something, and then saying, "Oh, this must be FND," because we don't know what else it is. FND is a real disorder by itself. It's identifiable. It's diagnosable as a thing. Next ones, patients exaggerate. FND is due to secondary gain, illness behavior. Well, this is an interesting one because symptom exaggeration or secondary gain occurs in some people with any illness. And at mild levels, even that can be quite normal. You know, I remember when I was a kid, kind of feeling a little bit ill and deciding I'd take the day off school. This is not a problem. The point is, this is not any more common in FND than any other illness. FND patients, in fact, I would say, in my experience, are amongst the most conscientious people. If anything, they are more stoical and conscientious than average. So then next one is FND is just anxiety or depression. It's not. Obviously, you can be anxious and depressed if you've got FND, and very possibly will be because it's a difficult condition. But that is not what FND is. It's a complex relationship, and it can contribute to maintaining the problem, and we'll come to all of that. So other myths, on the one hand, there can be quick recovery. On the other hand, it can't be treated. You hear both. How can they both be true? Of course, neither is true. So there's one idea that recovery should be quick because there's no structural damage. Well, it's a common misconception. And I think you'll sometimes hear this even from well-meaning neurologists. A small number of patients do get better just from being told the diagnosis. That's great news for them. But in fact, it doesn't spontaneously improve without treatment for the majority of people. And of course, as you're aware, there's a very wide range of outcomes. Some people can make a more or less complete recovery. And at the other end of the spectrum, for some people, it becomes a chronic illness. In between that, there are people who can recover substantially, but who have relapses or recover partially. So there's a very wide range. But it's only a small number who spontaneously get better. On the other hand, people say FND can't be treated, and once diagnosed, you never recover, or only neurologists or only psychiatrists can manage FND. So neurology does need to be the specialty that diagnoses people, and the first treatment is a good explanation of FND, but after that, the treatment is going to be by physiotherapy, occupational therapy, speech and language therapy, and psychology and psychiatry can be involved as well when needed. The most effective treatment is in a multidisciplinary team, and it very much is treatable. So next slide. Then there's this idea that FND is rare or new. Of course, it's not rare. I already mentioned that it's the second most common condition in neurology clinics. And that's a useful little factoid to have in your back pocket, because it makes people sit up and think, golly, that's really quite common. And it is quite common. You've all heard of multiple sclerosis. Well, FND is at least 3 times more common than multiple sclerosis, maybe more than that. You've definitely heard of motor neuron disease, and it's many times more common than motor neuron disease, 20 times of something of the sort. And just for comparison, depression, anxiety, very common conditions, but actually at the very upper end of the estimates for FND, it's beginning to get into that same order. Obviously, FND is not as common as depression and anxiety, but it's not an uncommon condition. Then people say, well, it's new. Well, it just isn't new. It's been around forever. Thousands of years ago, we have accounts of people who probably now would be diagnosed with FND from ancient texts. It began to be studied scientifically in the 19th century by doctors like Charcot and Freud and Breuer. Of course, somewhat problematically in Freud's case, it's been around forever. There are even, we might even look at some of Jesus's miracles and think, 1 or 2 of those look like they have a similar kind of symptom picture. FND, the myth FND is just psychological. Well, it plainly isn't just psychological. The symptoms are physical. The symptoms aren't psychological in form. They don't take the form of mood or emotional problems or behaviors. Physical illness or surgery is a common trigger. Research shows that biological or physiological processes and changes are at work. You can note that neurodiversity is a risk factor, and that's genetically determined. And the symptoms are due to abnormalities in patterns of brain functioning. On the other hand, FND does involve psychological processes. So the real problem here is to make that an either-or kind of a question, which is why I've put the elephant in the room up again, the mind-body dualism. Because let's look at this. Psychological factors are risk factors, including trauma in some people, but not all. Emotional processes and physiological arousal, which is a sort of technical term for what psychologists also call anxiety or stress, are a significant factor in triggering and maintaining FND. Expectations, including thoughts, are a significant factor in FND. Behavioral responses and coping strategies are a factor. Neurodiversity, appearing for the second time, is also a risk factor, and we can think of neurodiversity as having psychological elements. In fact, we can think of all brain functioning as psychological. It's not just me being a psychologist and trying to take over the world, but what we think of as psychology as specialists is that it's the science of what the brain does. It's a science of brain processing. And we can think of FND as a disorder of brain processing. Disorder of what the brain does, not of the structure of the brain. So it's both brain and it's processing. And we can link up the two things, the physical and the psychological. And so the usual way we talk about this is to say that FND is a biopsychosocial condition, and that helps that's a useful little word or phrase to come back to. Now, let's have a think about how this can be. And what I want to do is to share a very modern way of thinking about how the brain works, how we work as organisms. And a simple way of putting this is to say that brain processing creates the world. And there's a little diagram there which shows somebody with a brain in their head making predictions about the world and getting some sensory input back again. So this is how it works. What happens is that the brain predicts what it's going to discover. And your experience of the world and of your body, experience of everything actually, and this is a bit mind-blowing, is entirely created by your own brain, mine too. Everything that I can see in front of me, my computer, my screen, I can't see your faces, sadly, which I wish I could, because I like to sort of see people when I'm giving a talk, but I'm imagining you all. Everything I can see, which is mostly in my own house here, it's entirely in my own house, in fact, is created by my own brain. There's no direct connection between what I'm seeing and the world out there. My brain 100% creates the experience I'm having right now, but then it checks in with my eyes to make sure that its prediction is right, and it does that really quickly, and mostly that's really accurate. So actually, brain processing is the same as everything the brain does, and that includes all kinds of things. It includes thoughts, emotions, behavior, but it also includes sensory perception, vision, hearing, touch, body sensations, smell, taste, movement, hunger, thirst, pain, everything. Even the thoughts that I'm producing right now, also produced by the brain. You kind of know that, but it's worth noting. The brain creates the world we experience as well as our actions, and it creates experience itself. So if the brain is creating the world, then it can also create symptoms, and that's what's going on in FND. Let's have a look at that in a bit more detail. So first of all, let's get a sense for this idea of predictive processing in perception and in action. Optical illusions, or various sorts of illusions, are a good way of demonstrating this. Now, all of you by now will have been drawn to look at that nice little cat on the left there, because that's the most interesting thing that you can see right now. And our eyes will move to a face or an animal or a cat very quickly. So you've looked at the cat. And the first thing you will have thought is, that cat is sitting on a tub that is somehow floating above the ground, right? And then you'll have looked at the tub and you'll have instantly seen, no, that tub's sitting on the ground, but there's a stain just in front of it. And that looks like a shadow. And that's fooling my brain. And of course, that's exactly what's happening here. But if you look back at the cat, it will seem to float. If you look at the tub, it'll be on the ground. And you can go backwards and forwards as much as you like, but that's what it will look like. I think I can probably just about look at the cat and make myself see it as sitting on a tub on the ground. But you get the idea. It's an optical illusion. And the reason for that is because you're not seeing exactly what's there. You're seeing your brain's prediction of what's there, and your brain has got the prediction wrong in this case. The tub is not floating above the ground like some kind of science fiction sort of device, anti-gravity device or something like that. So that's a good example, and there are many others of how the brain makes predictions and to create our world. And sometimes we can sort of, pull the curtain aside and see that in process when you have an optical illusion. Now, here's another kind of illusion, and this one, because a lot of FND symptoms are motor symptoms. So I wanted to give you a motor example. So this is a good example. I'll play it again in a second if you missed that. This is a good example of quite a common illusion, which doesn't often happen, but maybe you've had the experience of picking up a carton of milk or something like that on the counter, But it so happens that it's empty, but you expected it to be full. And so when you pick it up, you sort of lift the carton super fast and high, and because you use too much force. So here's an example of somebody doing that on a video from the internet. They go to pick up the carton in the fridge. They expect it to be full. They use too much force, and then. So a good example of a prediction being wrong, and then the body does something which doesn't work out. So that's what we mean by predictive processing. Now, that's the theory underlying what causes especially motor symptoms in FND. That our brain is constantly, don't worry too much about the sort of other names for this. There's predictive brain, there's Bayesian brain, there's free energy principle. These are terms you might come across, and some of that stuff is really complex. And you can see how it's complex on the right-hand side there. Don't worry about the maths, it's just there for illustration, really. This is about the same thing I've been talking about. So perception and action work by making predictions. And then our brain checks those out against sense feedback and gets prediction errors, the difference between what we predicted and what's actually there, or what our body actually does. Then we update those perceptions, or we move as a way of updating the predictions. And there's a whole field of study about this. Carl Friston is the scientist who has developed.
Put my headphones
on. I think somebody's not muted there. Carl Friston is the scientist who developed this, and he's very clever, and there's complex mathematical models involved. And Carl Friston is famously difficult to understand. It's a kind of well-known fact. He's worth trying to understand because he's very clever, and some people think he's a genius, and that his theory will let us make huge strides in understanding living organisms. But I just mention it here. The simple way of understanding this is that minimizing that prediction error is the same as perceiving things and doing actions in the world. But it's like under the bonnet, that's what's going on. And usually that happens accurately. We perceive things accurately, and we take the kind of actions that we want to take, and our body does what we want it to do. But of course, that doesn't always work out. And you've already seen how that can go wrong in very ordinary ways with some optical illusions or even a sort of motor illusion. So in FND, we can apply this predictive brain model to understanding what's going on. And Mark Edwards, in a scientific paper with Carl Friston back in 2012, was the first person to outline this way of understanding FND, and we still think of FND in these terms. So in FND, you have abnormal predictions about what's going to happen, what your body is going to do. So these abnormal predictions are in the brain. They're unconscious. You can't access them. It's to do with the processing within the brain. And on the right, they just have a sort of schematic picture of how that works. Don't worry about it. It's just there for illustration. And also, attention increases the strength of those abnormal predictions. We call that the precision or the activation. The strength of those abnormal predictions is increased by paying attention. And when those abnormal predictions are very strong, then they're too strong for the incoming prediction errors, and our brain becomes unable to correct. And so then what happens is you get a movement which matches the abnormal prediction. So that's the theory of what's going on in FND. And that theory's been used in developing treatments for FND which work. And we'll come to that a bit later, and we'll talk about physiotherapy. At the same time, there's something emotional going on as well. When you research, and sorry about this, is a very busy slide. I'll just talk you through some key points. Again, it's largely there for illustration. The picture there on the right, don't feel you have to read it all. I will talk you through the key points. So at the same time, there are clearly some abnormalities of emotional processing or some differences in emotional processing in people with FND. And the research shows that what you have is you can find some pre-conscious processing of emotionally salient stimuli in the environment. That's going on more in the brains of people with FND, that you get increased arousal, increased sort of emotional arousal, that there's a disruption of top-down regulation of emotion, and that there's altered internal body sense of bodily emotional responses in people with FND. There are various things you can discover in research studies looking at neuroimaging and so on. You can show that the emotional areas of the brain trigger some basic emotional responses, which include motor responses in the brain. You can show that the emotional areas of the brain and the motor systems of the brain are hyperactivated, and that there's enhanced interaction between those two parts of the brain, or it's not just two parts, it's multiple parts, because the brain is complex, networked structure. And that happens during emotional processing in FND. So that the theory that Susanna Pick and her colleagues were putting forward a few years ago is that those emotional brain areas disrupt the neurological circuits which are involved in motor control and in awareness and emotion regulation. And that there are obviously risk factors for that, which are psychological risk factors, like having had adverse life experiences, but also biological risk factors of genetics or physical adversity like illness or injury, or other, a variety of other complex factors, which we don't need to go into detail about. So here's the idea of how these two systems can interact. And maybe we should stop thinking of them as two systems, because it's all one system in the brain. Susanna Pick's research group in London has published a couple of interesting studies. I wish I was giving this talk in a few months' time, because they're about to publish their follow-ups with larger numbers of people. So these two studies are with relatively small numbers of people, with 14 patients with FND, 14 healthy controls in this one. And it's a very interesting study. What they did is they showed people with FND some pictures. They sat them in a lab in front of a TV screen, a computer screen, and showed them a variety of pictures while they gave them some tests. So some of these pictures were sort of nice pictures, and some of them were negative pictures, a little bit upsetting pictures in one way or another. And they asked them at the same time to rate their levels of functional symptoms and to rate their level of anxious arousal, physiological arousal. And they had them wired up to measures to measure their heart rate and skin conductance. So you had some objective measures of their level of arousal. What they found was really interesting. First of all, the negative pictures were associated with increased functional symptoms and associated with increased autonomic activation, increased physiological arousal based on their heart rate and skin conductance. Their heart rate was going up, they were getting a bit sweatier. So show somebody negative pictures and they get a little bit anxious in their body, and that's linked to the severity of functional symptoms. Both of those things really interesting, but also thirdly, really interesting, that those people did not have good subjective awareness of their emotional state, of their level of arousal, because they rated that as well, and their ratings did not correspond to the actual measure. So there's a larger study to be published soon, and I'm really keen to see that because this is very interesting. Um, they did another study as well. This is really clever. They wanted to test this out in people's everyday lives. So they gave them an app to fill in, and the app prompted them 8 times a day to answer some questions. They were wearing a Fitbit at the same time to measure their heart rate. And what they showed, and that they asked them, what's just happened in your life? How are you feeling? These kinds of things. How are your symptoms? And what they showed was that over 7 days, the daily events and then their mood, their sort of their emotional state were the best predictors of functional symptoms. So again, in people's ordinary everyday lives, they showed a clear link between stressful events, how they were feeling, and how bad the functional symptoms were from moment to moment, or on a scale of a couple of hours kind of thing. So from these studies, my take-home message is that we need to target emotion awareness and regulation. There are two problems here. One is being aware of what's going on in the body, so that maybe it gets too much before it can be dealt with and noticed. And we need to improve regulation of that level of arousal, give people those kinds of skills. And that's really what my clinical work involves from day to day. So there is an issue about the terminology of anxiety and stress. And as psychologists, we talk about anxiety. We mean something different than what most people mean. And so when I meet a patient, I'm very careful about this, of course, because most people with FND that I meet, or many people with FND that I meet, don't relate very easily to the word anxiety. Because to a lot of people, what anxiety means is, well, I'm worried about something. And that's not necessarily the case, right? And people will say so. But what I mean by anxiety, stress, is something physical that's going on in the body. I mean physiological arousal in the brain, in the autonomic nervous system, in the endocrine system, like I've just been describing. So I think of anxiety as biopsychosocial. And we can use the word stress, or we can use the word anxiety. They kind of mean the same thing. Anxiety is the technical term psychologists and other healthcare professionals tend to use. But we don't mean being worried about stuff. We mean what's going on in the body. And it's maybe useful for you to have a little bit more sort of information about that. So in practical terms, what that feels like, I think of 3 different levels of anxiety. At the first level, you get muscle tension. And that could be lots of different muscles or just one place. We all know what that feels like. Right now, my muscle's a little bit tense here across the top of my shoulders because I'm giving a presentation. And there's a degree of anxiety at that level, but not very much. I'm fairly relaxed in my body, a little bit of tightness in my tummy. So there's some muscle tension. Next level up, known as the level of anxiety you get when you give a talk, is autonomic disruption. Here this is where you get sweaty palms, dry mouth, heart rate increases, you maybe get digestive changes, and higher blood pressure. Blood pressure goes up. You can't tell that because we can't judge our own blood pressure. So this is also anxiety, but now the anxiety is appearing in a variety of different forms, and they're quite physical. And these are body systems linked to the autonomic nervous system. So that's also all anxiety. I've got a little bit of it right now. My mouth's a little bit dry. That always happens when I give a talk. It happens to a lot of people when they give talks, which is why there's always a glass of water there. And I'm reaching for my cup of tea. And I'm having a sip right now. Okay, so that's level 1 anxiety. And the higher anxiety, level 2 anxiety, it's okay to dip into level 2 anxiety temporarily, but if you spend a lot of time there, then you start to get some physical symptoms like longer-term digestive problems, for example. And then that's not the end of it, though. You could go up to an even higher level of anxiety, level 3 here. Not everybody gets that, but people with FND more commonly do. And this is what we'd call cognitive perceptual disruption in the business. It can include dissociation. And here you start to get symptoms like not thinking clearly, confused thoughts, blurry vision, which comes and goes. You get more anxious, blurry vision, anxiety improves, the vision clears up. You can start to get mild dissociative experiences like derealization or depersonalization or full-on dissociation. And this level of anxiety is associated with functional seizures, for example. So people with FND more prone to that level of anxiety. So 3 levels of anxiety is a good way of thinking about it. And what you're noticing from what I'm describing is I'm really describing very physical states of the body. That's what I mean by anxiety. So let's go on to look at the models of what's going on in practical terms in FND. So this is a great body of work by Glenn Nielsen and his colleagues. Glenn is a physiotherapist, and he ran a multi-center treatment trial for FND, for functional motor disorder, and they published their findings just a year or two ago, quite recently. And they also published their treatment manual a few years ago. And in that, there's a nice description of their model of how it works. And you'll see over on the right, that's that diagram. And you can see that they're examples of a kind of ordinary problems that can arise in motor control are the same one I showed you, the picking up the carton, the empty carton, or stepping onto an escalator which isn't working, and suddenly your body doesn't quite know what to do, and your movement goes wrong. Another way that you can demonstrate sort of ordinary disruption of motor function is if you pay too much attention to your ordinary movements. If you pay attention too closely to how you're walking, you start to not walk very well, and your sort of walking goes a bit wrong. So they highlight those kind of ordinary experiences as a way of explaining what can go wrong in functional motor disorder, and then how to treat it. They make use of distraction during physiotherapy and other techniques. So this is a good an interesting document to have a look at. There you can find it on the internet using that QR code. In functional seizures, there are various models, and I'm not going to show you all of them. Some are a bit complicated. This one has such nice graphics that I recreated it. This is from Stoyan Popkirov's presentation at the last FND conference. You can actually find a really interesting talk by Stoyan online by going onto the website View Medi and just searching for Stoyan Popkirov, and you can watch it. It's a half-hour talk where he describes this model. And he also puts arousal in the very center. So this is a model of functional seizures now, and arousal is in the very center, as well as expectancy, which can affect arousal, leading to dissociation, as I was just describing in the levels of anxiety slide, and some behavioral response. In other words, the functional neurological bit where there are some abnormal movements or other symptoms. And some of this response is the activation of innate motor programs, and some of it is the activation of acquired motor programs, the functional neurological ones, which we already talked about. We talked about what the model there is. And what causes arousal? Well, all the usual things cause arousal: some sort of conflict or discomfort, even physical discomfort or illness, emotional conflict of various kinds, which can come from what's happening right now. And that can be linked to vulnerabilities from past experience. And of course, suggestions or cues can become associated with this reaction, and they can be triggering it as well. So various reasons why this reaction can be triggered, and then it is triggered. And that's a way of understanding what's going on in a functional seizure. I like a super simple model where on the one hand, we have anxiety dissociation, and on the other hand, we have a transient functional neurological state that occurs. And that is super simple. Here's a complicated one from 10 years ago now, when Marcus Royber, who's a neurologist, and Richard Brown, who's a psychologist, produced this model. I'm not going to go into this in detail. It is rather complicated, but the idea here is this sort of nuts and bolts of what's going on inside when there are functional seizures. What I'll just note is that if you look at this, then you can see bits of this which are to do with anxiety and bits of it which are to do with the functional neurological element of it. So let's move on to talking about treatment and management of FND. Armed with these theories that we've been talking about, and I hope that was interesting to you, armed with those theories, people have gone on to work out, well, how best to treat this. One of the big changes has been what we might call the revolution in diagnosis. A lot of this is down to John Stone and Alan Carson and the work that they've done over the last 20 years or more in shaping up the diagnosis of FND. So key point that there are positive signs, and I mentioned that before, rather than it just being a diagnosis of exclusion. It's important for a neurologist to check there's nothing else going on neurologically, but having done that, that's not enough just to give the diagnosis of FND. You need to find positive signs in one way or another to be sure of it. And those positive signs are definitive, because when you see those positive signs, you know, well, this is functional. Obviously, a neurologist needs to do this because they need to understand the nuances of it. This makes it a medical diagnosis like any other medical diagnosis. John Stone's advice to doctors is don't be weird, because in the past, doctors would get all sort of tongue-tied and nervous when talking about functional neurological disorder. And of course, that is not a sort of encouraging experience if you're a patient, being spoken to in that way. You might start to think, well, what is it about this diagnosis which is making my doctor be a bit weird? So I like this phrase, don't be weird. Of course, when it comes to diagnosis, sometimes it's unclear. If it is unclear, then that's not a positive, that's a negative prognostic factor. Having a clear diagnosis is really helpful for people with FND in various ways. First of all, you want to know what's wrong with you. And once you do, then that takes away a bunch of concerns about not knowing what it is and imagining all kinds of things. Maybe for people it's different. But straight away, you begin to change the abnormal prior beliefs or expectations, which are part of what goes on in FND, which I was talking about earlier on. That's why for some people, that's enough for them to get better, even though that's relatively uncommon. So there are positive signs, and I'm going to click through these slides fairly quickly. There's a lot of detail and we don't need to see it. But here, just to illustrate, here's a whole list of kind of positive signs that neurologists are looking for. And right there in the picture is an example of looking for what's called distractibility in a functional tremor. So you can see the person's hand is tremoring in the one picture. In the other one, the person is doing something with their other hand. They're copying the neurologist's hand movements. Because they're concentrating so hard on those hand movements, same time their other hand seems to stop tremoring. And that is one of the positive signs. It can be very useful for patients to have that pointed out and to see for themselves. See, neurologists could point out and say, look, when we do this, then your tremor stopped, didn't it? Well, that's really interesting, because if it was caused by a neurological process, then it wouldn't stop, would it? Just because you were paying attention to something else. And that can really make sense to people straight away and say, oh, yeah, okay, I understand. So this is a functional neurological symptom. And then the neurologists hopefully go on to explain what that is. There are other positive signs here in various sort of arm and leg weakness, and I'm not going to go through this in detail. And here's a kind of infographic which John Stone and his colleagues produced in 2020 for other doctors to communicate this kind of thing. There's functional limb weakness, that's what you're expecting. There's the Hoover's sign, the hip abductor sign. There's a couple of positive signs there. In functional movement disorders, with a fixed dystonia, or a facial dystonia, or the one I just showed you, the tremor. And in functional seizures, there are certain signs which are very likely to indicate that it's a functional seizure. So functional seizures are characteristic. And these days, the diagnosis is often by taking a home video, and then showing it to the neurologist. And the neurologist will be looking for some of these signs, like eyes tightly closed, tearfulness, longer than 5 minutes, side-to-side head shaking, hyperventilation. Not every seizure has all of these features, but when you do see these features, those are characteristic of a functional seizure. And in functional vision, there's another kind of sign there. There are other signs there. Just to go on a bit about the seizures, here is a page from a paper by Gaston Baslet 5 years ago, looking at those different features of seizures. And over on the right, which I've sort of highlighted in red, you can see the percentage likelihood that somebody with that symptom would have a functional seizure. And you can see that these are very high. You know, if there's a waxing and waning course, it's 96 to 100% likely to be functional. If it lasts more than 2 minutes, it's 93% likely to be functional. If you have asynchronous movements, that's 82 to 100% likely to be functional. The eyes are closed, 98 to 100% likely, and so on. There's a bunch of these things. So if you have a few of them, the diagnosis can be really pretty certain. So what about treatment? Well, first of all, a positive diagnosis helps. It can correct incorrect expectations, and that can actually affect at the unconscious brain level prior expectations, because the brain is massively interconnected. So our thoughts can actually affect how the brain functions. And then we can treat by multidisciplinary therapies. So the question is, how do we change these abnormalities of brain processing? And obviously, we can't get into the brain and actually do things to it. Instead, we have to use the tools we've got available, which are talking and movement and activity and skills training and the senses. We have to help people from outside, so to speak. And that's what we mean by these therapies: physiotherapy, occupational therapy, speech and language therapy, psychology. So we look at each patient and we think, well, what are the best levers or set of levers for this patient and this problem? And then use physiotherapy, occupational therapy, speech and language therapy, psychology, any other therapy, or whatever we might use to try and get at that in the best way possible. So this is in the ideal world where we have a multidisciplinary team and we can work in a coordinated way, because it also needs to be in the right order. Maybe the physiotherapist and the psychologist need to work together. Maybe you have to do one of these before another one, or be flexible about that. Medication, of course, might be a part of all of this if it's useful for some people. Usually surgery is not going to be a solution. But of course, any tool, as long as it's got a role, could be part of a treatment program according to an individual patient's needs. So we now have pretty good ideas of what you do in these various therapies. And there are these um, uh, guidelines out there in the published scientific literature. If you're interested, you can find all of these by finding those QR codes. Essentially, in physiotherapy, one of the key components is to use distraction, because remember how attention is an important part of making the symptoms worse. So you can use distraction while eliciting physical movements, and that can elicit normal movements, and that can be shaped up. Then I'm just looking at my watch, and I think I've been talking for a long time, so we started a bit late, so I got confused. Right. In psychological therapy, basically any therapy, and some of them have strengths and weaknesses. I use mindfulness training myself. Anxiety regulation is a central part of what we would do. We would base our work on a formulation of individual patients' needs, and ideally embed that in a whole system management. So you have a specialist service, have first point of contact, but multiple connections between all levels of the health service, so that people are held at primary care, secondary care, and if needed, at specialist FND service level before going back to being supported by colleagues in sort of secondary care and in primary care by GPs and so on. So what is FND? It's a biopsychosocial disorder. It's a disrupted physical function from disrupted brain processing. We talked about predictive processing and abnormalities of brain expectations. Talked about symptom-focused attention. We talked about emotion processing abnormalities and physiological stress or anxiety, and the management via multiple therapies, ideally in a multidisciplinary team and in a whole healthcare system, with the aim of gradual rehabilitation or optimized management. We know what we're doing now. We just need a chance to do it, and there are signs of hope for that. Here is a document that was published in August last year, it's a boring document, but you might be interested in reading it. The National Neurology Service Specification. And then a second one published in October, the NICE guideline on rehabilitation for chronic neurological disorders, including acquired brain injury, also FND. Both of these documents include FND, and that's really the headline here, because FND is now, through these documents, an absolutely mainstream part of neurological and neuro rehab services. Various recommendations are made about the service that should be provided. So there should be access to neurologists, investigations, should be more follow-up, there should be access to mental health assessment and treatment, to an FND specialty team, an FND MDT, to referral pathways for comorbidities and community rehabilitation. All of those things, basically a comprehensive clinical service. And this is now laid out in the guidance. This is what we have to provide. We're not there yet. There's also guidance for what should be provided in a specialized neurology center. There's obviously some sort of extra specialist things and contacts back to the secondary care centers. The implications are that this is now, FND is now one of just 7 neurology subspecialisms, putting FND on an equal footing with things like epilepsy and neuromuscular disorders and multiple sclerosis and those kinds of conditions. It's a huge shift. It doesn't yet mean we've got all these services, but it means that the policy is in place. So if we go back to our stock take of my tick boxes, we do have a specialist understanding of FND. We do have patient understanding of FND when that's well explained. We don't have healthcare workers understanding FND well across the system. Some do, some don't. Still not good enough. We definitely don't have a society level understanding of FND. We do have treatments. We do have national policy. And I've put a small tick in FND treatment services. We do have some FND treatment services. It'd be wrong to say we don't, but there's a lot of room for improvement. Okay, and so next steps will be to educate healthcare workers. I think it's very important, build societal awareness, very important, and to fund better services. Those, in my view, are the three main things we need to do. And we're going to all be working on that. Thank you so much. Sorry for